you.
There you go, we're now live. Good afternoon, everyone. Welcome to another Positive Choices Lunch and Learn session. My name is Neil Hudson-Basing. I am supporting Positive Choices on this series of lunchtime lectures. I work at London South Bank University. I'm just going to read a short webinar statement with you first before I talk you through the functionality. So everyone attending or speaking at one of our Positive Choices events, whether in person or virtually, should be treated with respect, dignity and courtesy. Positive Choices operates an environment built on equality, inclusion and acceptance. We value contributions, feedback and comments and wish to create a space for sharing, learning, celebrating and bringing communities together. Positive Choices does not tolerate any form of bullying, abuse, harassment or discrimination. Inappropriate behaviour, including that potentially impacts or contradicts Positive Choices' reputation and values, will be treated seriously and acted upon. Anyone exhibiting any example of this behaviour will also be removed from the webinar. We want our events to be an enjoyable and warm experience for all. Thank you for adhering to these guidelines. So just to take you through the Zoom functionality very quickly before I hand over to Helen, you'll see the chat box and it's absolutely lovely to see everyone making use of that already. Please continue to do so. Share your thoughts and comments in there and help us to break down the virtual wall that we're all experiencing at the moment. The next button along is the Q&A function. We've already got some questions in there. Keep them coming in. You can upvote on the questions that you most want answered by clicking on the thumbs up symbol. Without further ado, I'd like to hand over to Helen.
Okay, good afternoon, everybody. I hope you're all settled with your lunches and whatever and ready for what I know will be an amazing session. Hello, Mary Reedy from Waterford. Lovely to see you, well, virtually. This topic came about, it's almost a little bit out of sequence in terms of our dates and whatever, in response to several discussions that I've had with several people of the panelists, notably David Charnock and Scott, in relation to equity and vaccines and so on and so forth. And I talked to David about I wanted to do this as a lunchtime seminar and how could we do this. David has ever stepped up to the plate with what I hope will be, well, I know will be a really interactive session with all of us. So the panelists are going to work as if they were the question time panelists. Chris and I are going to keep an eye to the chat, and in true BBC fashion, we will jump in every now and again with questions and comments that are coming from you in the chat session. But as Neil says, please use the Q&A as well for stuff that we're going to answer at the end of it. So after about 10 minutes, Chris will have kept a record of the first 10-15 minutes and ideas of what he wants to feed in, and then he will hand over to me for the next 10-15 minutes so that we don't get word blindness from the screen. So without further ado, it is my great pleasure to introduce to you my esteemed friend and colleague, David Charnock from the University of Nottingham.
Hi everyone again, my name is David Charnock. Helen's just said my name, but I'm Assistant Professor at the University of Nottingham, working with people who want to be learning disability nurses. So I'm going to call on each panel member now to just introduce themselves. So if we can start with Sarah Clayton.
I wasn't expecting that.
Sarah.
Oh, right, so my name is Sarah. I work at Simple Stuff Works, so I support families and people with complex healthcare needs. But Helen asked me here today as I'm also a parent of a young woman with a complex brain injury who falls between lots of different labels, but basically presents as someone with a moderate learning disability. So yeah, that's me.
Great, thanks, Sarah. I'm coming to you next, Rachel Wright.
Hi, I'm Rachel Wright. I am founder of Born at the Right Time. I'm a qualified nurse and a particularly unqualified parent of 3 children, one of whom has profound and multiple learning difficulties. I'm really passionate about building bridges between families like mine who have young people, children, adults with complex needs, and the many practitioners who support them. I do that through CPD accredited training, through parent workshops, And I'm also really dedicated to salt and vinegar crisps and hummus.
Excellent. That's really good to know, Rachel. Over to you now. I'm coming to Helen Atherton now to introduce herself.
Hi, I'm Helen Atherton. I'm a lecturer in nursing at Leeds University. My background is learning disability nursing, and I'm also the co-editor of Learning Disability Towards Inclusion, the textbook that many of you probably come across. And I'm here really to give, I'm not quite sure yet what my perspective's going to be, but it's going to be interesting to hear this debate and on the range of opinions on the use of particularly the DNRs around people with learning disabilities. I'm quite looking forward to hearing what people have to say.
You're also, Helen, a nurse historian. You always forget to tell people that.
I do, I keep that bit quiet.
Hopefully we're going to draw some of that out today, Helen, so that'd be great. Right, I'm coming for you now, Joe Kiernan. Joe, are you still there?
Yeah, I am. Sorry,
Great.
thanks.
That's all right.
Excuse me, apologies. Yeah, my name's Joanne Kiernan. I'm a lecturer in learning disability nursing at Edgehill University, but also for the last 5 years, I've been the consultant learning disability and/or autism nurse for Alder Hey Children's Hospital. And yeah, I'm really looking forward to this.
Great, thanks, Joe. Now coming for you now, Deborah Moore.
Oh, hi, I'm Deborah Moore. I wear a number of hats. I do work for NHSC, but I'm here today in my role as a learning disability nurse. I've been a consultant nurse for near 20 years, thereabouts, so it's quite a long time. So I'm delighted to be amongst such esteemed colleagues on a very important topic today.
Great, thanks, Deborah. Now I wonder if Scott Watkins, if you could introduce yourself to the group, please, Scott.
Hi everybody, I'm Scott Watkins and I'm a person with lived experience. I'm also head of engagement at Seeability, and I lead a team of people with lived experience to make sure that they're getting their voice heard across all the issues that we're campaigning about across the country at the moment, especially around the pandemic and COVID, and talking about equality and how we should be prioritizing people with learning disabilities and autism and making sure that everybody has a voice. So I'm here to really just tell you as it is, really.
Great, thanks Scott. That's exactly what we need. I wonder if I could ask Eddie Chaplin to introduce himself, please.
Hi, my name's Eddie Chaplin. I'm a mental health nurse by background, and I'm currently a professor at the Institute of Health and Social Care at London South Bank University.
Great, thank you, Eddie. And finally, Steve, if you could introduce yourself, please.
Hi there. My name is Steve. I'm a nurse, and I'm also representing Peter and Sandra as two self-advocates from Lewisham, and they're also co-editors of Peter and Friends talking about COVID. Thank you.
Great, thanks, Steve. Okay, just to kick everything off then, I'm just going to talk
David,
briefly about...
David,
yeah.
Don't forget Rebecca.
Oh, Rebecca, sorry.
And Chris.
Oh, and Chris. Yeah,
no,
Chris,
no,
Rebecca first.
Okay, I'm just a little old liaison nurse here in Galston, trying to get it right.
Sorry, Rebecca.
Trying to do the best thing that I can do for people with learning disabilities and autism across the eastern counties here. So yeah, that's what I'm just a little learning disability nurse who loves people with learning disabilities and their family carers, trying to get it right all the time.
Thanks for that. And now finally, Chris. Sorry, Chris, I'd forgotten you.
Good, no, it's all right. I'm not a panelist today. I'm just facilitating the discussion, but I'm a nurse first and foremost, and I'm a senior lecturer at Teesside University. The last 12 months have been a complete revelation for us as a field of learning disability nurses and students and all those vested interests. And we've learned so many lessons, and coming here today to listen to this esteemed panel expressing their views about what has been happening, I think is going to be influential, especially for our future nurses who are listening here today. I know there are some who are doing this for exams, especially whatever you hear being said here, please reference it, because a webinar can be used as evidence, and all the people here are experts today. So feel free to record and reference everything you hear, because your exam will be super duper powerful. Thank you.
Great, well said, Chris. Thanks for that. Right, so we'll get started then. I just wanted to say something initially about why I became interested in this. So, like all of us, in February, I was kind of listening to the news. I was reading things about what was happening over the pandemic, and particularly what was happening to people with learning disability. And I ended up with an email from an organisation called Sputnik News International. And although I thought immediately, oh my goodness, my email's been hacked by the Russian government, and they're going to take everything I own and everything I love. That wasn't the case. Olga was a real person, and she wanted some questions answering. And I don't know how she got to me, but she just wanted the questions answered. And she was interested in two things. So she was interested in the idea that a government, a UK government, had made the decision to force do not resuscitate notices on people with learning disability who had contracted COVID, and that was a real worry. But the second thing she was interested in was what influence that would have on whether people were going to get vaccines or not, and whether people with learning disability were going to be on those lists. And that kind of got me a bit angry and got me a bit fired up to answer these questions. So I immediately got onto that and managed to get a couple of quotes in her publication, which was great. I then started following Jo Wiley on Twitter and what she was saying about a sister with Down syndrome, and just the fact that people like Jo were getting the vaccine earlier than people with learning disability who might have a lot more issues around their health that would mean that they would need protecting. And so from that, I had a conversation with Helen, and we're here today to have this debate and start to think about and answer some of the questions perhaps that most of us have. So we're going to start with a question. I'm directing it to Deborah Moore to start off with, and then we can all kind of say something about what we think about this. So Deborah, I wonder if you could think about how do we make sure that those who make big decisions about health remember that the lives of people with learning disability actually matter?
Sorry, you're on mute, Deborah. There you go.
Oh yeah, you're on mute, Deborah.
Yeah, that's what I was just checking in the chat.
The line of the century, isn't it?
Yeah, I've got a poorly dog behind me at the minute, so I'd muted in case there were any noises that disturbed people, and then forgot I was still on mute. So, wow, thank you for that. That's a big question. Yeah, and it's not something I think that only applies in relationship to the COVID situation and the DNA. So I'll take it in that context, because I hope what I'm going to say as a utility when we're facing other kind of life or death type situations, or other serious quality of life issues that people make judgment decisions about people themselves. So I think I'd start with first saying that, and I suppose in ways it goes without saying, but I think it's worth repeating, is we should let people and families say this for themselves first. So I think when we're trying to make sure those who make big decisions, do the right thing and understand that the lives of people with learning disabilities matter, there is no powerful way of doing that than letting people speak for themselves. And so, I think there's something about us as allies to create as many opportunities as possible, like you have today, to actually hear from people and families themselves. So, if you're thinking about people who make big decisions, chief execs, MPs, members of parliament, etc., then we collectively need to think in big and small ways about every opportunity to create a space for people and families to speak for themselves. So if you're working in, I don't know, in a local area, and you're invited to do some training, I don't know, for your GPs, let's just take that one as a fairly frequent example, that you absolutely stand by the principle that it will be co-presented and people and families will have centre stage. And I think even to the extent that you'll turn down the invitation should that not be favourable to the audience. And I know people say, well, yeah, we're doing that for years, but you'd be surprised how many times it doesn't happen. And there is, and then I suppose as it gets further up the system, the times that happens get less and less in my experience. So it's up to all of us to network with people who do have an opportunity at a national level to engage with people who make big decisions, who tend to be people with big titles, don't they? To again bring people with them, but give the airspace to them, because you know we know this because we're passionate about being allies. But you know, people after me, people with learning disabilities and their families, to truly understand and know second-hand narrative from somebody like me, or book or article, will ever have the effect. If you're thinking just about quality of life, you know, is it worth spending else money on this group? Let's, you know, cut to chase. Then you know, for that person who's making that big decision, for their mind to be changed, let's say their mind is not favourable, you know, the only way that'll happen is they actually see what valued citizens people are with learning disabilities, what love and joy and reciprocal relationships they bring with their families and their friends and in their neighbourhoods and communities, and all the things that we know, and that's best understood in that environment when people and families are present and have the most airtime. Our gift, I think, as allies, is to garner some of the science and the data and some of the stories and oil the wheels, and you know, because again, you know, there's a power in stories, but equally there's a power in science. And I know again colleagues on the call have you know, worked hard and published on Twitter and social media, etc., compelling scientific evidence about what's the right thing to do. But you need that marriage for me. You need that marriage, but we must always make sure that we involve people. And then I'll not go on too much, David, because I'm sure others who are on the call have got, you know, certainly more personal experience than I have of this. But I think there is something about harnessing citizenship and politics in its widest sense. So, you know, it might sound tangential, but we have to remember people are citizens and they have a vote, and there is a process for lobbying your own MP and for putting in parliamentary questions through that route. And these are the things that will make people make big decisions nationally. These are the things that will get them exercised. Honest, I mean, I've spent some time on the side of that fence and seen what gets them exercised, and people writing letters to their MP or, you know, attending all parliamentary committees, etc. You know, it will land in people's consciousness in that fashion as well. So you know, people with learning disabilities voting, you know, being again invited to places of power. You know, it's that speaking truth to power thing, locally, regionally, nationally, and make your business to find out how to do that.
Okay. Great, thanks Deborah for starting us off. I think that issue of allyship and being great allies is a really strong point. And I wonder if I could bring in Scott at this point to ask you to take that on a little bit, Scott, and talk about, you know, what do you want us all to do in order to make sure that people with learning disability are not forgotten when we talk about health?
Yeah, thank you very much, David. I think there's a few things that need to happen, and I think one of those things is around actually you guys are a great network, and actually working together with you guys to make sure that people with learning disabilities are not forgotten and are up the top of the agenda is absolutely brilliant. I think it goes wider than that as well, because actually one of the things that don't happen is Department of Health and Social Care, and there are teams within NHSE don't talk to each other about actually knowing the knowledge of working with people with learning disabilities. And actually it's not good enough. they need to be talking to each other, but also be asking us as people with learning disabilities ourselves, what are the issues here? Why have we got these issues? And actually, this has been so highlighted in the media, that lack of accessible information, lack of prioritization of the vaccine, and but actually this isn't new though, is it? It's across the whole of everything within health and social care, within the area of learning disability and autism. So it isn't new. And actually we have self-advocacy groups and those and people there who really can make a massive contribution to this, and are really keen to be shouting out there and having their voice heard and saying it as well. And I think we need to be looking at making sure that everyone's voice is heard. But actually I think there's something around, we're fed up of being listened to and saying, oh well, we're really sorry that this has happened. We want action. We want to see action happening now. And if and actually and the DNAR stuff, it's just, who the hell thinks it's so right to put a DNAR on somebody just because they've got a learning disability, just because they don't think actually they're going to survive through COVID, and or anything? It's because the doctors and nurses who don't have the learning disability awareness training do not understand, do not get it, and think, oh, this is too much. We'll just make our lives easier, and we're just seeing as not human beings.
Yeah, well said, Scott. And everybody, there are lots of people on the call today saying you're making a really good point there. You know, why would you do that? Why? What are we saying about the lives of people who have a learning disability? And you're right, you know, this isn't a new issue. And, you know, I wonder if somebody else on the call could come in to talk about the issue of evidence. So we've got, you know, this plea for, you know, the voice of people to be heard, and that was certainly silenced, or has been silenced, I think, over the last few months with the issues that we've had. But also we've got a body of evidence that seemed to be ignored about people's health. You know, does anybody want to come in and just say something about that? How do we strengthen the evidence that's already out there to say, actually, people with learning disability have lives and they really matter?
Can I just say, David, because I think it's really interesting what's been said. You know, fundamentally, nothing is going to change. You can generate as much evidence you want, objective research evidence you want. Nothing is fundamentally going to change unless care is underpinned by the right values. And this is what's going wrong, is that the people don't have the right value set. They don't have the right attitudes towards people with learning disabilities that are going to facilitate equitable care, that value judgments about somebody's quality of life and not going to be made. And I think it's because they aren't in receipt of the right type of evidence. And it was something that Deborah said that kind of resonated with me, and that is that doctors and nurses in hospitals don't see people with learning disabilities unless they are ill. They see them at their most vulnerable, at the weakest points in their life. They don't see them when they're at home with their families, enjoying their lives, enjoying their day-to-day activities. They don't see that, so they just see them as very vulnerable. And a large part of this is because they don't get exposed to people with learning disabilities enough in a range of different situations. So their value base is not being challenged, their attitudes are not being challenged. And if you do look at the evidence, if we talk about evidence, if you do look at the research evidence, there is proof that if you integrate people's life stories and personal narratives into training, you get a lot better response. You get people who are more able to empathise with somebody's situation, and you get a lesser kind of expression of these negative attitudes. So I think it's not more to do with, we can, you know, we talk about health being generated and the evidence around health, but we've been generating this evidence for donkey's years. I can't even tell you the number of health policy documents about people with learning disabilities that have come out over the last 20 or 30 years. There's been, and it just keeps the roll and roll and roll, because fundamentally we are not addressing the key issue, which is how do we ensure that people have the right values? Can I have the soapbox now?
That's fine. I think that's a really important point. And I think, you know, is it the stories, those life stories, that will help to bring along that body of evidence and convince people? So are you saying that it's about training, but it's about the content of that training that's so important, Helen?
Absolutely. And, you know, this is quite kind of pertinent in this issue, because we're just about to go to the 7th edition of Learning Disability Towards Inclusion. And ever since that text has existed, which is now in something like its 35th year, there has been a chapter on causation and manifestation of learning disabilities, where we've had pages and pages and pages of saying, right, this is what causes a learning disability. If you have Down syndrome, this is what it looks like. If you have Cri du Chat, this is what it looks like. We've just got rid of it, because both myself and the other editor, Debbie Crickmore from Hull University, said this is distracting people. Those labels, whilst they serve an purpose in terms of giving some idea of what type of thing you need to look for when you are meeting somebody with a diagnosis like that, they're helpful to some extent, but actually what it's doing is it's labeling people to the point where that is they're defined by that label, not who they are. So we're going to get rid of that, and we're going to say, right, instead, we are going to have a chapter that says you need to find out about people as people, not the label that they carry. Because just because you've got Down syndrome, it does not mean that you are going to be like everybody else with Down syndrome. You are an individual, and your life and you have been shaped by very individual experiences. So we've got rid of that. Now that might come down and come back to bite us, I don't know. But it could be deemed quite controversial to do that. But we felt that was one of the issues, that we have to move away from this notion of labelling, and that being the sole interpretation of somebody's needs.
Yeah, great. Thanks for that, Helen. I think that's, again, a really kind of strong point about, you know, labelling and what that kind of means for people. I wonder if I could bring in Joe and also perhaps Rebecca, you know, as working as part of healthcare systems, and this kind of difficulty in making sure the voice of children and adults who have learning disability is heard within those settings. And I think Helen's got a really great idea about making sure those stories come through. You know, what's your view on that? What's your view on how we hear those voices?
Hi, David. Thanks. Rebecca, do you want to start?
If that's all right, I wish I'd brought pen and piece of paper, because there's a few things that I want to comment on. So the DNA CPR forms are they're culturally bound, and sometimes you're looking at people who have been consultants or doctors in acute hospital trust for a long time with embedded cultures. And what I'm finding is, and I haven't seen an inappropriate DNA CPR form for the last 5 years that I've been in practice, because I review every single one in the hospital, and I have to say I haven't seen one. And the one that I did see within those 5 years, I challenged the practice immediately and educated that clinician. They were with a consultant who, you know, does have questionable values, and I've challenged that as well, and recorded that. But yeah, that person's cultural beliefs then changed invaluably, actually, just by having that conversation. But I want to build the point of the respect forms. So the respect forms that are in use now are there to promote those conversations about people's wishes, and the respect forms are there to have people's voices heard. So I think we really need to promote our families, our loved ones, if we work with colleagues, with GPs, with nurses, for everybody at every opportunity to have conversations about what people's wishes are. It's not for people at end of life. It's not for people, you know, I've made my family aware, and it's documented that should a tree fall on my head, they know what I want. Should my heart stop tomorrow, they know what I want. And that's not because I have anything. I've got, you know, I'm very healthy and well. But if I don't record it and I come to hospital and I'm not able to verbalise it, people may well make assumptions about me. And I don't want anything about me without me, and neither should a person with a learning disability. So I would always suggest, please, please, please have those conversations about the respect forms. They were designed to eradicate the thing that we're discussing at the moment. And I was shocked to hear when I had this conversation with some community colleagues, they hadn't even heard of a respect form. So I just want to ask the panel, has everybody heard of respect forms? Yeah, good.
Everybody's nodding. So yeah, that's again really important points about you know, respect of making sure that a voice comes through at that critical time when the person is coming to hospital. But I want to take you back to the point you made about, you know, do you think it's time for, you know, truly focused training? So if somebody, you can see somebody has the wrong values, you know, we are kind of focusing our attention on that one person for a period of time so that we can get them to change. Have we got to that point, do you think, in this, where it's about group training, but it's also about getting hold of people and saying, well, you need to change this now?
Yeah, I think we can all say in our experience as nurses and other professionals, do you know who those people are that maybe have values that challenge our own? And I think it's you know, for you know, I'm an old lady now, so I've been doing it a while. So I don't worry about challenging practice, and I'm very confident in challenging the most senior clinicians in the trust. I do worry about our younger, newly qualified nurses who maybe worry about challenging practice. And I think there's something there for giving people the confidence to have those challenging conversations. And if they're met with conflict and with values that don't meet their trust values and behaviours, then that needs to be called out as well. And I think the more we do that, the more we will eradicate. And I constantly mention when I'm challenging practice, you know, the leader reviews, the you know, all of the other things. Your work is now going to be looked at in lots of other areas, so you need to be very mindful of your decision making and be very clear on how you're evidencing your decision making, because it will be looked at, and and that's a beautiful thing to be able to say, because it gives us the backup, really.
Great, thanks for that. Joe, can I bring you in now for your comment on some of those issues, please?
Yeah, David. I'm just really mindful Steve's had his hand up for a long time, David.
Oh, sorry, I can't see any hands up, so I'll come to you next, Steve.
Yeah.
Thank you.
Yeah, I think from my perspective, I'd really like to bring the children and young people's voice into this, really. I think going back to some of Helen's points, you know, that historically, you know, our vulnerable groups, if that's the right language, I'm not sure it is, are those people who, whenever we have something like this, a national crisis, or that we tend to find that society reacts in a particular way, and it sort of exemplifies everything that lots of us have been working with and practicing with for many years, and lots of people have experienced. And it sort of brings, I felt this pandemic has brought the very best and the very worst out in people, to be honest, and it just magnifies everything for us all. But particularly around children and young people, I think, you know, that there's been some reactive, there's had to be, we've not had this pandemic before, there's been some reactive approaches to the way we've tackled this. I mean, things like the clinical frailty scale, some of those initial things that came out via NICE just completely set us off on a what I felt was quite a reactive road in our organisations when we were trying to support people. But from a children and young person's view, that they seem to be, you know, it's difficult for a child or young person to have their voice heard. They sit within layers of hierarchy, and then let's put the fact they're a child or young person, the fact that they're a person with a learning disability and or autism, and the fact that they may be in a you know, in my environment, a very medically dominated field, where actually, you know, mostly adults know best is the sort of feeling there, you know. So if you start to layer up your parallel stigmas, you know, as Duncan Mitchell talks about, you start to think about the voice of the child, young person. My experience, I've got to say, in clinical practice has been quite positive, in that very early on it was felt that our ethical panels needed to strengthen, and that's why I talk about NICE and the clinical frailty scale, because that didn't send us off in the right direction, but actually those ethical panels were set up very early on to try and look at some of these issues. really, really lucky that children and young people predominantly haven't been badly affected by the coronavirus. So that evidence was filtering through as we went. But of course, if you're attending hospital, you're amongst some of the most vulnerable groups. You're coming for a reason, you're coming for issues related to your healthcare. And one of the things, going back to the data that Rebecca's talking about, is the absolute power of that data within an organisation to affect that culture. So I'm happy to share, and we can evidence that coming through our outpatient department in a children's hospital on any one day, we can evidence 35 to 40% of attendance of children and people with a learning disability or autistic spectrum condition. Those are those children and people who we know of, so they've got a diagnosis, bearing in mind that lots of people attend a children's hospital for diagnosis, so they're on a pathway, we haven't got that diagnosis. So actually, when you start to use that data alongside things like Rebecca said, actually the child, young person might not necessarily have a voice, but the adult and the family, the carers have a voice. But also we as practitioners have a voice in evidencing this isn't one or two young people coming through our organisation. This is half of your patients coming through your department. So actually, as an organisation, we need a strong procedure, policy, practice and culture that enables us to respond appropriately. And some of that information, along with LEDA, along with our evidence base, along with our training, and our campaigning that Deborah talked about, is how we enable a voice at all levels, including collaborating with those young people to make sure that that care is bespoke around reasonable adjustments and truly listening, because you know, Helen's right, you know, we have children with Down syndrome coming in. Each and every young person is completely, and if you think, you know, as we all know, that you've met one person, so you know everybody, we all know, don't we, how individual each and every one of us is. So actually just that message within an organisation is, you've got a pathway. Just to let you know, 99.9% of our children, young people aren't going to fit that pathway because kids don't, full stop. You know, then put on the fact that they won't do it anyway because they don't like the colour of your top, you know, and then you start to have an organisation that's a little more open and prepared to listen. So I'm going to stop there because I started waffling. I do apologise.
No, I think that's really important. I think the numbers bit is really fascinating for me because, you know, the difficulty is we don't have great data, great numbers, but when you talk about it from your own kind of experience of seeing that, that's when it really comes to life. And I think that's really I mean, thanks for reminding us as well that as well as the worst during this pandemic, we have seen some of the best. And I think that's important to recognise too. But yeah, the numbers.
David, can I come back just one second? That I think my challenge is here, and I think I've heard a couple of challenges from the panelists so far, is we didn't have that data. Let's go out and find it. Let's make it local. Let's make it meaningful. And then let's share it far and wide so that the power of all those voices of that collective is there in our organisations, because people don't have a voice if they're not noticed or supported to be so. Sorry, I just had to finish.
Absolutely, yeah, I think you're absolutely right. And if everybody could do the same thing, we would have a better picture of who we were talking about and how many people. Steve, you wanted to come in, sorry. I can't see any hands, so you'll have to wave at me.
Oh, you're welcome. First of all, I'd just like to go back to the DNR situation. It's really great in the area in East England that Rebecca lives. But there's much more evidence across the country and Wales and Scotland that it does still occur. And we've had examples in our local press and on the leader reviews as well. So this is still happening years and years after it started. So something's got to be done. I mean, I think the letter from NHS England is really helpful, but I don't think it will change too much. Peter, I spoke to him today, and Sandra, they said, well, things need to change, but they said they lost faith in the power of advocates, etc. So they said we need to, like Debbie said, we need to lobby MPs, we need to write to our MPs. They've marched on Matt Hancock before this pandemic. It was to do with the ATU situation, and then also on Skipton House at Elephant and Castle. But, you know, he spoke to me about how Jo Wiley is a really lovely, lovely lady, and you mentioned her. And she actually emailed me afterwards. But, you know, it takes a celebrity to go on the Andrew Marr show to actually bring a light on the issue of people with learning disabilities, when so many people I personally know have been on BBC News, ITV News, Sky News, and they've spoken out, but they weren't listened to. Yeah, so I think we really need to take a really good, great stand, you know, and I'm often blamed to be a activist or a you know, a leftism person sort of thing. But, you know, we need to do something. You know, we've been going on for years upon years. They're not second-class citizens, they're third-class or fourth-class citizens. And we've had enough. Sorry.
Yeah, absolutely. And I think some of that is coming through with the people who are kind of listening to this debate as well. It's about, you know, taking action. So it's an important thing to raise. And I was kind of thinking also in all of this, you know, is it about finding celebrities to do this? Why does action happen when somebody steps forward who's well known? And I think we need to kind of change that narrative, certainly. I wonder if I could bring in Sarah and Rachel to think about parents for us for a moment. So in thinking about those big decisions that are being made about people with learning disability and their health, you know, how best can the support be given to parents to affect change and take action? I don't know who wants to go first, either Rachel or...
Well, obviously Sarah's going to go first because, you know, she's just that kind of person. So it's over to you, Sarah.
There you go, Sarah. Yeah, go for it.
Thank you. And first, I think there's so much in this conversation that is about stuff that's wider than healthcare. And when you think about kind of people that are attracted to medicine, and we think about the overrepresentation of people from private schools, and we think about the education system that segregates children from a very early age, and we think about, you know, Helen mentioned, you know, that in books you have to have, you know, and for years there's been descriptions of kind of somebody with Down syndrome, because somebody with Down syndrome didn't sit next to you at school. And if you haven't, you know, kind of, it's so much wider. That's just what keeps coming to me as we talk, just listening to you talking. And, you know, Deb, when you were saying about hearing family stories, and one of the things that, you know, kind of, I can't remember how long you and I have known each other, and hearing those stories, if that doesn't move people to action, then all that is voyeurism. Mm-hmm. That's all that is. There's nothing more than that. So don't ask families to go through, you know, like kind of families put themselves through it's traumatic explaining what's happened to your child, and to, you know, the way that your family was, you know, this self-sufficient little bubble, and then it became public property, you know, that. And I think there's some stuff in there about power and shifting power. So unless we can truly shift power, and that means shifting money, and it means, you know, as a parent, I don't want to ask to be listened to. I want just to get on with it. You know, I don't want somebody's permission to live a particular way. I just want to get on and do it. And then I was thinking about this idea of big decisions and parents, you know, kind of thinking about, you know, kind of big systems and NHS England and all of those things. And that overwhelms me. I can't, my brain doesn't, you know, it just makes me think, what? But what I can do is keep pulling stuff back to small decisions and small relationships, like the relationship we have with our GP is why Abby got vaccinated early, you know, like end of January. So there's something about, I might not be able to influence NHS England, but I can influence my GP, and I can work really hard on the relationships that we as a family have with the small group of people that support us. and then I'll stop there. I'm going to stop now because otherwise
on
they'll
you.
accuse me of
Again, some really important. But I think that thing about, you know, this isn't just about one system. This is about all systems. And if you don't get change in all of them, then you don't get change in anything.
It's about, yeah, it's a complete lack of visibility, a total lack of value, and a recognition that when the fault lines, these fault lines have been here for forever, and they've been blown wide open, and people have died as they've fallen through the cracks. And nobody, you know, I could go down a sweary route there. Nobody gives a shit.
Yeah.
Do you know what I mean? Like,
well
kind of.
I thought that was going to be worse, but yeah, well done.
Usually is.
How do we without having to divulge personal information to make people see that my girl is worth it, nobody else has to do that. Nobody else has to explain what, you know, that they have a life outside of this hospital appointment, and for that life they deserve to have good treatment. Like, why does she? What, like, you know? So yeah.
Yeah, that's a really powerful point. Rachel, were you about to say something?
Well, I've got so much to say, but I'm not sure. I'm not sure I'm in sync with quite a lot of people. So as far as the big decisions go and the parents, I think we've talked lots about the system, and we've talked, you know, and Helen's talked about from the values, and Sarah's talked about values and stories and embedding people's lives. There is a little bit of parading people for a purpose. It's interesting, isn't it? I think there is a real question as to why does somebody who's a Radio now 2, in my day she was a Radio 1 DJ, but a radio DJ and it's because people have assigned themselves as the same as her, and suddenly, because they've got this "we're the same" thing, then their mind is open, like, oh, and she's, oh, that's interesting. Whereas if you bring on the person with a learning disability, or the family of the person with a learning disability, well, they're still other. And so we have this value system that starts with our kids. You know, I went a bit silly over a pesky post that I did a couple of years ago on 100% attendance awards. And it was a very flippant kind of thing. But the bottom line is we teach our children, whilst they're in reception, 5, 6, 7 years old, that the important thing is to be well and go to school. And being clever, because you've gone to school every day, is what's important. Now, if we're instilling that within our children at 4, 5, 6, 7, 8, then it's not surprising when they get to be, you know, the doctors, the prime ministers, the whatever else, that those big decisions, that's in their DNA, that's in their thing. So in some ways we can challenge the big decisions. I do think there is a problem with us driving stakes in the ground. You know, I really think that when we stand up and shout, all we're going to get back is shouting. And actually there is a way that we can work with people, sharing that data, sharing that voices. And I don't underestimate the pain of not being heard and not being represented. But my son has a DNR, and I don't think this conversation around DNARs is actually expressed very well, because I think it gets mixed up with quality of life, and I don't think that's the decision that's being made. And I think it gets mixed up with this one choice. This one, if you get to the point where somebody's heart has stopped, then that is something very different. There are so many decisions that happen before then that we need to be talking about, and what Rebecca brought up with the respect forms. You know, that's where the decision is. I think we're having the wrong arguments, because we are mixing, we've all watched too much Baywatch, and we all think that if you jump on someone's chest, then they're going to cough a little bit of water out the side and they're going to jump up again. And that's not what it's like. So we need to have conversations, not where we're abandoning it, no one should have DNRs, but where we have conversations, those understanding what they do, what they mean. If somebody dies in hospital, what is the chance they come, you know, what are we losing by keeping that by keeping someone for CPR? And are we losing a good death? Are we losing the opportunity for their family to be there? So I just don't think it's as simple as we make out. And I think there is a lot of, and I want, assure you, there are actually some really good medical practitioners there. My husband's a GP. Obviously, I'm going to have that on our side in the back of my head. And I know that when they got the first lot of vaccines, they went to learning disability homes and they vaccinated a lot of them. They were like, we're not waiting for the government to say this is the time. And they thought at the beginning that they weren't going to get paid for it, because they were like, it's ridiculous. If we're vaccinating all the over 80s, we're vaccinating the people who are who've got, because their risk is with others. Their risk is about their not just their own conditions and things, the comorbidities or whatever that might be involved, but it's the number of people that they're in contact with. So there are people making good decisions, but unfortunately they are being made sometimes contrary to what's being fed down from high. So big decisions, it's about the system, but we change the system by changing our values, not pitying people, but actually valuing people.
Yeah. And I think that's a really strong point, and making sure that value happens, and that then has this knock-on effect. I agree that it's about personal decisions. It's about having conversations, and I think that's coming through really, really, really strongly today. Eddie, I wonder if I could bring you in to, what are your thoughts about, hearing people's voices and changing systems and, influencing those on high by working on, perhaps restructuring certain things. What's your view on that?
I think sometimes we have the tendency to celebrate our small wins too much. I think what we were saying about evidence and training, that sometimes we place too much emphasis on these. They're very important tools, don't get me wrong, but they're only part of a toolkit. And they're not the greatest things in moving values and culture, like I've said before. And I think it's what people were saying. You need to start really from kind of childhood, how we socialize people. Because I think one of the most disturbing things that I've seen, we hear about horrendous deaths still, but we think that we're on the right track. Then all of a sudden, people are making, or it's suggested that they're making blanket decisions about a whole group of people, not giving them a choice whatsoever. And that kind of shows that we haven't had the impact that we want, or people are paying lip service and reverting to type what they know best, which is wrong. So I think at the moment we're at a kind of crossroads where, this is such powerful information that we should kind of keep on, because from previous kind of campaigns, we've had Leader, SIPOLD, we've moved a bit, but often we don't see our things. We have to look back to look at progress, because it's often very slow.
Yeah.
And I think that this kind of last bit of momentum and thinking of ways that we can change the kind of cultural norms of people, because people are employed, they'll say yes to anything. I think a lot of the times, if they're in a training situation, it's, tell me, can we go early if we don't have a break? These are the kind of main concerns, whatever the training's about, even if they've kind of waited ages for it. So I think really it's time to kind of perhaps take stock and look at what we need and what parts the evidence we have done and the training plays, and what's the best way of going forward to try and stop this type of practice going on.
Yeah, great. I think that's a great point about, I think this is the pandemic for people with learning disability and their allies and everybody. It has brought us to a bit of a crossroads, and it's time for kind of looking back perhaps. And that leads us nicely into bringing Helen back, because I wonder if you could delve into the past for us. Helen, is there anything we can learn from the past that will help us ensure that good decisions are made for the future? Is there anything we can learn from that?
One of the problems is that people aren't aware of the past and things that have gone on that they can draw parallels with. And certainly over the past few years, I've kind of made it a priority of mine to start to educate people about different areas of history that can be drawn and used to actually begin to look at some of these decisions from a bit more of an objective perspective, to try to use history as a kind of, I think in one publication I talked about it being a yardstick to measure it again, to look what actually are we seeing. And that can be quite a complex thing to do, because things aren't as straightforward as possibly people make them out, but certainly history can play an important role in trying to get us to understand what we're seeing and what we need to do about that. So in terms of parallels, in terms of what we're seeing, we need to really look back in terms of the eugenics era, which is back end of the 19th, beginning of the 20th century, whereby there was very much these value judgments made about who constituted quality members of the population, and what criteria were in terms of being regarded as having a valued life. And it was valued in terms of what people could contribute back to their societies, often kind of financial contributions, things that would help with society. So you have got a very strong message at the back end of the 19th century, early 20th century, that people with learning disabilities did not constitute quality members of the population. And in fact, we needed to be doing everything we could to try and prevent or at least limit their existence within the population. So you have issues around countries introducing compulsory sterilisation to stop people from breeding. You have the history in the UK of people being put in institutions, again, segregated from society, but also segregated within those institutions, again, for the purpose of them not breeding or propagating their poor genes, as I think, it has been put forward in those kind of ways. But then you see this issue of value of life and these value of life judgments coming in much more acutely when you come into the 1930s, 1940s and look specifically about what Nazi Germany did in terms of deciding basically who was to live and who was to die. So it's a very similar situation in terms of the fact that at that particular time, there were deemed to be insufficient resources to maintain their population. There would have to be decisions made about where those resources were going to be placed. People with a learning disability, people with mental health problems, people with physical disabilities who were in hospitals at that particular point were deemed to be a drain on these precious resources. They were deemed to have a life unworthy of life, which again, we're coming back to these value judgments as well. And as a result of that, there was justification for them being destroyed. And in fact, I was thinking just before I came on, that, if you look back into this history and you look back at specific examples, there were the textbooks of children at various young children, there were mathematical workings out for you to do. If you have so many people with a learning disability in this hospital and it costs this many Reich marks, how many pots of jam can we afford to give our soldiers? And that it was all attempts to ingrain that these people, they not only lack value, they are people who are not only affecting the quality of a population, but also we shouldn't have to pay out for them because they don't contribute anything back. And I can see parallels in some of the thinking that drove those decisions today. And it's not just around the use of DNRs. Let's broaden it to prenatal testing. Why is it all of a sudden that for years and years and years, prenatal testing for Down syndrome was given to women above a certain age, offered to women above a certain age, and now all women are offered it. So that, to me, that's a question I'd like, I don't know that I don't think I've ever had an answer on that one, that's why that's been rolled out to everybody. But equally so, some people would argue that this, what we're seeing now, is not eugenics on the basis that it's at the level of the individual. So these aren't broad programs that affect the whole of society, that's from the government that was orchestrated. This is individual choice, but it's not. Because there's evidence to suggest that when women go for prenatal testing, they aren't given objective evidence to make decisions. They aren't, some cases, afforded information given by families who have got children with Down syndrome as to what this situation is like. So they're not making objective, informed decisions, and there is some evidence to suggest that there is a push towards them having the abortion. And so it's almost like if you have the test, the outcome will be the abortion.
Yeah, I get.
David?
Yes, really. Yeah, Steve, is that you?
Oh, so I just got a very quick point. I totally agree with, because today's laws will be tomorrow's crimes, and it goes back from the institutionalization through to even 10, 20, 30 years ago. The restrictive practice we were practicing as a normal kind of practice about 10, 20 years ago, and it's now illegal. 30 years ago, we were going around sticking ammonia up people's noses if they go banging the wall. They're not allowed to do that now. Even with the push of inclusion of people only with learning disabilities only need general nurses. They don't need a learning disability nurse. That's changed. So yeah, I mean, what we're looking at today may be seen as a crime in 10, 20, 30 years.
Yeah. Can I just come in there?
That's interesting. Yeah, sorry, Deborah. Yeah, go ahead.
To build on Steve's point, I think this is really important, and I think certainly because I'm very old, I kind of remember that the biggest changes have occurred for me in how we are in health services. I'll stick to health services because that's mainly my background, but social care as well. Is when power shifts, when people, families are in those powerful places speaking for themselves. I know I mentioned earlier about speaking for yourselves. I want to come back to Sarah's point though about not re-traumatizing people. There's a difference in speaking for yourself and giving an opinion about a policy, how we spend our money, what decisions we make about schools and where we spend them and all of that. That's what I mean by giving people a voice and making sure that you don't speak for them, because Sarah's more than able than I am to say about inclusive education than me. So if I got invited to the party, I'd be bringing and saying, this is the person you need to speak to, who can advise you properly about what you need to do. But for me, there is that thing about power. There is the values piece for absolute sure, but people who don't respond to good values respond to power. And that's the truth. And we have to power and money. And we learnt this long ago with personalisation. You follow the money and things will change. And so I'd say to nurses, get more political. And I'm not quite as out there as Steve, God love him. But I'm like you, Steve. I think we have to tread a balance between being absolutely outraged and being objective. And sometimes we get it wrong. But we have to know which tool to use at which point, and to be a good ally and all of that. I want to just say one word though, just about, because Scott's not here now. I'm sure he would remind us of this as well. We do have to be careful when we invite people to do training with us, or we invite people to come to meetings with us or whatever, about how we ask them, what we ask them to do, and are they comfortable with that? Because some people's experiences has been so horrendous and for so long. So it's either minor slights that have gone forever, terrible one-off things, a combination of all, that we logically are in danger of re-traumatizing people. So I'll just leave it there. And
totally agree.
Could I just say, Deb, that's
Sarah.
It's and that's it exactly, because having known Deb for so many years, I know what is intended. If Deb were to ask me to speak somewhere, I know what the intention is. It's just about that clarification, because so often if a family is invited to share an experience, what they're invited to do is not to give their opinion on, it's about kind of resharing, listening to their story kind of thing, and it's about the difference between the two. So thank you, Deb.
It'd be very triggering for people, and we need to.
Yeah.
Could I say something? Can I just come in with a question, please? I realize that we've got 24 minutes left and
we're running out of time. And so if I can bring Helen and Chris in now for any questions or anything.
There's a question from Amy Smith here. Unfortunately, Scott has left, but basically to summarize it, Amy wants to know what recommendations, Rebecca, especially you spoke about that. What recommendations do you suggest for ensuring our clinics are fit for purpose when it comes to vaccinating people with a learning disability?
Oh gosh, engagement. Yeah, so I had multiple engagement events with families and friends of mine who have children with additional needs, and adults who are also friends with additional needs. So it's just engagement. Listen to what they say, put it into action, get your CCG involved from the outset, and don't wait for guidance, make your own.
And could I say, Rebecca Crossley, that if I ever hear you publicly again say, I'm only just a little learning disability nurse, I'll come and bite you. Because who out of all the LD population has been contacted from as far afield as Canada in the last few weeks to find out how they can make their vaccine services more effective for people with a learning disability? So you're all my witnesses. If she says it again, I'm going to bite her.
Can I say don't wait for guidance? So something Sarah said, and the other parent, I'm so sorry, I'm terrible with names. You know, you've got your vaccines early. Yeah, don't wait. And that's the thing. I think people are waiting for this. It's guidance. It's not statute. It was a guidance document. None of it said you have to wait. You have to do this. If you're worried and your loved one can't cope with an oxygen mask or a cannula, that's the treatment for COVID. And if your loved one can't cope with that treatment, they are incredibly vulnerable to the virus. So I would say, you know, my criteria for the clinic is, can you have an oxygen mask? Can you have a cannula? How would you worry if your loved one or you got COVID? What would happen? Tell me about it. And if you got COVID, who would look after them? And if they can't answer that, then you get the vaccine. And if this person can't cope with treatment, then you get the vaccine. I tell you what, why don't you all come and you all get the vaccine? Save problems.
Right, yeah, thanks for that, Rebecca.
Can I add in there, David? Just
come in,
children, young person point of view, and just a little bit of humour, really. We had some issues when we started to flex back up to make sure that some of our most needed patients in relation to the treatment that might have got postponed because of COVID early on, and then we had our sort of hit list of who needed treatment, you know, priority wise, and some of those children, young people on that list were children, young people with learning disability and or autism. So then there was this very brief conversation about, well, will they cope with the screening, the COVID screening, you know, in order for them to come through the hospital. So the good news was that we created about 5 or 6, 7 different ways that we could make that happen for the child. But one of the ones, and I'm saying this from a humour's point of view, and people might have come across this, was our drive-through service. So where that child, young person would come with a family member through what looked like a drive-through, and probably thought they were getting a Happy Meal, but actually got a swab stuck up their nose, and etc. etc. So just to say, if anybody's had that experience, I think potentially some of those poor young people will never want to drive through ever again. But
hey, don't do that. We've got drive-through vaccines. You'll scare them off.
Well, that's right, Rebecca. Yeah, so they'll never believe you again when you say you're going for a treat for a drive-through, just in case anybody has an adverse reaction to that. But what we managed to be able to do, and not just us, I know it was done across the country, was bespoke some of that. There was a fear that they wouldn't cope with it, and our pre-op, so for instance for theatres, when I actually went down there and said, okay, so we're struggling to get children screened then so they can come in for the theatres, and this very what's the word, candid nurse said to me, who said that? Because that's not true, because we'll do what we need to do, and we'll spend as long as we need to do to make sure those children get their screen and get their surgery. So actually this, what was potentially a problem, was being talked about, was being shared, wasn't in reality, and wasn't for the families or the children, young people. So there is a bit of myth busting, isn't there, Rebecca, that has to go on?
There is, totally. And once the media gets hold of something, they can terrify families. I've had families calling me saying, oh my gosh, what would happen to my loved one if they come into the hospital? And I say, you've got nothing to fear. We will manage that, and let's get it all written down now, shall we, and all on the computer now. So I'm getting calls on a regular basis of families terrified, and that's the media frenzy, and it's not okay. They need to stop.
Okay, thanks for that, Rebecca. Just before I hand back to Helen and Chris to sum up and to pick out what's been talked about among the group that are listening in, I wish I could. I want to do that kind of question time thing of coming to each of you with a question and just get a one-word answer. So I'm going to try and do that in the true spirit of Fiona Bruce. So who should be making the decisions about good health for people with learning disability. I'll come to Rachel first.
It should never be one person, because one person never has all the information that's required.
Great, thanks. Joe.
I think it's the person or the people nearest the person, but with going back to Rachel's point, with all the information, because without the information you can't make an informed decision.
Great, thank you, Joe. Steve.
Just listening to the people, actually keeping the person at the centre of everything you're doing.
Okay, thank you. Rebecca.
Yes, without a doubt, the person and the people that love them, because they're the ones that are going to help us make the right decisions.
Great, thank you. Sarah.
Keep doing that. What Rachel said, there's never one person, and it's recognizing that whilst a parent may well have absolute expertise in their child's condition, they may not have that same amount of knowledge about all the other elements. So it's about recognizing parents and the person and those very closest to, but also that there are gaps in that, and that you need that full group of people.
Great, thank you, Sarah. Eddie.
I think what really Rachel and Sarah said, but with the person leading that process where they can.
Okay, thank you, Eddie. And Helen.
I think Eddie summed it up, that it should start with the person and where they're unable to make those kind of decisions, or then with other people. I think it's wrong to just have one person involved, because it needs to be looked at from many different perspectives, and we need different opinions on what needs to happen.
Great, thank you, Helen. Okay, so we've talked about a lot today. We've raised a lot of points, and there are many new debates that could come from what we've talked about from the past and from what's currently happening. So thanks to all the panelists, and thanks for your for speaking up and for your expertise. I'll just hand back to Helen and Chris now for any views from people listening in today.
Thank you, David. Helen, do you want to go first?
No, you go first, Chris, because mine's an observation rather than a whatever.
All right. Also, as facilitating behind the scenes today, I have been listening, and these are some of the issues that I'm quite passionate about as a person. But one thing that I've observed, that when you work in learning disabilities in whatever role, and if you are involved with a person with a learning disability, I can assure you that you are angry at least once a day. At least once a day, because what we see happening out there, it's like there's a learning disability is a language that's spoken by us nurses and families of people with a learning disability, and therefore we feel, or we are looked at as a group of people. You know, we're categorized. Our views, it takes a lot for them to be heard. That's why it takes Jo Wiley to speak and be heard, because she's known. We're like an unknown entity, and the frustrating thing about it is, if there were as many learning disability nurses in the UK as there are adult nurses, and you asked all adult nurses to stay at home today and put all LD nurses, the job will go well. If you put all LD nurses on an off day and ask all other nurses to work, there will be many things that go wrong. And that shows us that learning disability, what I'm saying, is a language that many people still do not understand. And whether it's going to take some cultural upbringing, as some of my esteemed colleagues have suggested, or a change in our value basis, how do we grow up as a nation? What do we teach our children as they grow up about health and disability? And until those things are cultivated from the floor, it's going to take a long time. You know, one thing that frustrates us as LD nurses, it's only until someone has broken a law. You know, we look at valuing people, we look at the Equality Act. It's only at those points that people start getting into trouble, when a person with a learning disability has been ill-treated. And it should not be about the law controlling what we do. It should be about our values. How do we feel? That's why when decisions are made, we are always at the back of the queue, supporting people with learning disabilities. So with all these things, health inequalities, there's millions of research evidence there. Restrictive practices, Steve mentioned a few of those, diagnostic overshadowing, some of them have got phobias. What structures are there? So when a person with an LD goes for a vaccine, what structures are there, you know, except for Rebecca and a few others who know that that needs to be done. Nobody else cares. So are those facilities provided for us? And you find that there's nothing. So in terms of our values, in terms of supporting others outside LD, I think these are the things that we need to be driving forward in order to change cultures in terms of changing values, and not worry about breaking the law, because we shouldn't be worrying about the law. It should be an internal thing about our morals and our values. Thank you.
Thanks, Chris. Thank you. Helen.
Okay, the first thing I want to say is thanks to you, David. You know, this was what should have been a corridor conversation, but was one of our, I'm having a cup of tea, you're having a cup of coffee, let's talk to each other on Teams conversations that seem to happen most days. And you straight away stepped up to the plate. So I'm going to finish very quickly and ask you to sum up rather than me sum up. But I would be really remiss if I didn't say that at the start of COVID and lockdown, having been a registered nurse in learning disabilities since 1982, say that very quietly, that my whole practice ethos was changed by Rachel and Sarah. Now, my first contact with Rachel was when she interviewed me for Simple Stuff Works website, which was a lovely experience. But Sarah and I have been friends for a long time. And they asked me to come along to a workshop that they were running. And I think I was there to be, I don't mean this to sound horrible, but I was there to be a name, really, as somebody. If Helen goes, other people will come next time. That's not a problem. If you've got a name that people know, then use it. That's all I say. And I do admit to it being an early morning start and me thinking, oh my God, I've got to put proper clothes on, not just pajamas, and be dressed and made up for early on in the morning. But I, within minutes, was humbled by the stories people were saying, and particularly one mum who talked about having to show her son's bum on a camera to a GP to look at the potential of a pressure sore. And it moved me so much so that I needed to write about it. Unfortunately, LDP gave me the opportunity to write about it as an editorial. So your practice can change. So being a registered nurse of a few years standing, actually getting up, not wearing pajamas and putting on proper clothes to be part of that panel for Rachel and Sarah changed my practice and changed my practice forever. So thank you very much for that. In the chat, I have put the link to Helen Atherton's amazing article about finding Ivy, which I think you should all read, because, yeah, definitely you should all read it. And I will just hand over to you, David, to finish, because you're far more equipped to do that than I am. You've been amazing, David. Thank you.
Yeah, I think for me today has, you know, given me more food for thought. So, you know, those ideas, those feelings that I had when I was watching all of this being played out, and what a year we've had. I think this debate has kind of raised more issues and raised more thoughts for me, and I'm sure it has for those people who are listening. You know, the idea that we should truly listen to people, that we should truly listen to people who have a learning disability about their health, to their friends and their family, but also to the allies that support them. And I love the idea of, you know, creating, you know, true allyship with people with learning disability to make sure that change can happen, but kind of realizing that it's a massive issue. And we have to begin to tackle this now. As Eddie said, we're at the crossroads of something. We need to decide which direction we're going in, and the enormity of that. So it's not just about what happens, what we've heard about, but it's about how society works, what values they have, what values people have who work for the health service, and looking how we change that. We've heard, you know, Joe reminded us of we have seen the best, but we've also seen the worst. And I think that's an important thing to walk away with from today, but also from Helen, you know, those echoes of the history and eugenics in all of this, and trying to think about how we address that in order to help us to make decisions about the future, I think is an important point. Listening to those voices, so not forgetting that it's about children, it's about young people, it's about adults, it's about everybody who's within this kind of story. The whole thing about the do not resuscitate orders and how that was presented, I think we've got lots of food for thought here. And remember, it's about that conversation. And I loved Rachel's discussion about the fact that it is about having a conversation. It's not about a simple fix to this. It's about a much more complex discussion and a much more complex listening. Something that we're trying to do here to make sure we're hearing truly the voices of those individuals. So, you know, it's a big thing that we need to do, and it's now is our time, I think, to start to kind of move this forward. So I hope this debate is the start of something, and the start of your thinking about this, and hopefully we'll move on now, thinking about the numbers, thinking about how we create better numbers, think about how we create the right sort of evidence that moves us along. So I thank the panel most sincerely for their input today, and also thank everybody who's listening today. And I just hope it's sparked some thoughts and some discussions for you as you walk away from this session today. So thank you.
Thank you.
Fabulous, thank you. Neil, as always, we will be putting this on the Positive Choices page as a recording, so people can access it again in their own time. We've got another session, Lunch, Learn and Celebrate, booked for April. We've got a bit of a longer break now because it comes into Easter, and as a lot of us are academics and we're in silly marking season as well. And I believe that's about, it's going to all be led by people with learning disabilities. Isn't that right, Chris and Steve?
Yes, correct.
Yeah, Lucian speaking up and dance syndrome.
Yeah, so all sorts of bits
others that are going to come in as well.
Yeah, so absolutely fabulous. And also we will then, Helen Atherton has agreed to do another session later in April, beginning of May, specifically about the T4 protocols and eugenics and what we need to be aware of and where we're coming for where that's concerned. There are lots of tweets out there, brilliant tweets out there today from the session. I will also, with some partners, be doing a Lunch, Learn and Celebrate session on going to the dentist, because this week, this week I've managed to secure the support financially and physically from the British Dental Association to produce a resource specifically for adults with learning disabilities about going to the dentist rather than children. Thank you, Steve. So more about that later. So I'll just let you do our, who's talking, Helen?
Me.
Hello, darling.
Yes. Spent all of yesterday in the dental hospital with Abby, and it was bloody brilliant. So if you want any help with that, I would love to help.
Okay, well, I will be looking, Sarah, for some lovies to come up to Durham with me, where the HEE have got their practice dental surgery, where we can use all their equipment. So maybe herself, the elf, would like to bring her sewing up there and do it with me.
She would have to be. She would love to. Can Rachel? All right, well, we don't go anywhere without each other.
Yeah, of course we can. Yeah, of course we can. Yeah, so we'll get that sorted.
Sorry.
All right then. Thank you. Pity you live in Ireland, Mary. Well, yeah, well, we could fly you across, honey. Waterford's not that far. As always, we're indebted to Neil, who is our superstar, not just because of the amazing shirts that he wears and he keeps us all in check. But is there anything you want to say, Neil?
No, not at all. Just that keep an eye out on the Positive Choices Facebook page. We will share the event there. One thing to flag up, Helen, is that if people don't have access to the Positive Choices Facebook page, it might be worth popping these on YouTube at some point, just so that they can be widely accessed.
That might mean you helping me set up a YouTube channel then.
Put me on the spot, but deal.
You know you love it. Somebody's just asked me then about will they automatically get an invite? No, you won't, but we do advertise it on Facebook and we advertise it on Twitter. And I'll think about the person that's just asked that, I can't see your name now. If you email, all right, if you email Chris or I, then, oh yeah, Hayley, then Hayley, so my email is just helen.laverty@nottingham.ac.uk, and I'll make sure you get to find out. Okay, right, lots of love, everybody. Stay safe.
Thanks, Helen.
Thank you, everybody.
Thank you.
Bye.
Bye.
Bye.